cavernous sinus and applied anatomy. So in this we will be discussing one competency, that is about dural folds and dural venous sinuses. Coming to dural folds, the meninges consists of three layers, that is dura, arachnoid and pia mater. The dura is composed of two layers, that is endosteal layer, that is outer layer, also called as periosteal layer, and meningeal layer, that is the deep layer. And the picture showing the layers in order, that is endosteal layer of dura, the meningeal layer of dura, the arachnoid matter and the pia mater above downwards. The endosteal layer lines inner surface of calvaria. Meningeal layer or the dura mater proper is firmly attached to the endosteal layer except at the sites where it forms venous sinuses and at the sites of dural reflection. It communicates with the dura of the spinal cord at the level of foramen magnum. So you can see in the picture the dural venous sinuses which are present between endosteal layer above and the meningeal layer below, that is duplicated. Coming to dural folds or reflections, there are 4 double foldings of meningeal dura. They subdivide the cranial cavity into subdivisions. The largest of these is falx cerebri. It is sickle shaped. It is a midline reflection. It extends between two cerebral hemispheres vertically. It extends from the frontal crest anteriorly, frontal crest and crista galli anteriorly to the internal occipital protuberance and superior surface of tentorium cerebelli posteriorly. Then we go to another dural fold, that is tentorium cerebelli. It is the second largest reflection. It extends horizontally between the cerebellum and the cerebral hemispheres. It divides the cranial cavity into supratentorial and infratentorial spaces. This is crescent shaped and has a free and fixed margin. The U-shaped free margin is called as tentorial notch. The fixed margin adheres to clinoid processes, superior borders of petrous part of temporal bone and margins of transverse sinuses. Then we go to diaphragm cella. It is circular in shape and forms the roof of cella thoracica. It covers the hypophysis cerebri and has a small opening in its center that allows the passage of the infundibule of the pituitary gland. Diaphragm cella extends from tuberculum cella anteriorly to the dorsum cella posteriorly. And the last of the dural folds is the falx cerebelli. It is sickle shaped, small sickle shaped dural reflection, and it extends vertically between the two cerebral hemispheres. Then we go to dural venous sinuses. So in this picture you can see the cavernous sinus on either side. Then we can see the sphenoparietal sinus, and inside the cavernous sinus you can see the internal carotid artery and the abduced nerve, and in the lateral wall we can see the 3rd, 4th and 5th cranial nerves. And coming to tributaries, we can see in the picture the inferior petrosal sinus and the superior petrosal sinus that continues as transverse sinus and subsequently as sigmoid sinus. So dural sinuses or venous channels, they are between endosteal and meningeal layers of dura. It is lined by endothelial cells and internal elastic lamina, but they lack the muscular and adventitious layer of other veins and are valveless. Superior sagittal sinus. It is in the upper fixed margin of arc cerebri. It extends from crista galli anteriorly and ends at the level of internal occipital protuberance posteriorly. It deviates to one or the other side, usually to the right side, and becomes continuous with the transverse sinus. It has a triangular shape in cross section. Then other dural venous sinuses. Inferior sagittal sinus runs in the free margin of arc cerebri. At the level of free margin of the tentorium cerebelli, it joins the great cerebral vein of Galen to form the straight sinus. Then straight sinus. It is formed by the union of inferior sagittal sinus and great cerebral vein. It runs in the junction between falx cerebri and tentorium cerebelli and ends in transverse sinus. Transverse sinus, they are paid. They start at the internal occipital protuberance as a continuation of superior sagittal sinus and other as continuation of straight sinus. They end by turning inferior medially to form sigmoid sinus. Sigmoid sinus, S-shaped sinus that begins as a direct continuation of transverse sinus. It enters posterior part of the jugular foramen to become continuous with internal jugular vein at the superior bulb or superior jugular bulb. Occipital sinus. It is the smallest of all sinuses and lies in the midline near attachment of falx cerebelli. It starts at the foramen magnum and ends cranially at the confluence of sinuses. Occasionally, two occipital sinuses are present. Cavernous sinus, the important sinus. It is a pair of dural venous sinus located on each side of the body of sphenoid bone. It has four walls: medial, lateral, superior and posterior walls. The posterior wall forms the communication between the two cavernous sinus. So picture again showing the cavernous sinus, its contents, that is internal carotid artery, abducted now, and contents in the lateral wall, that is third, fourth and fifth cranial nerve. Fifth is ophthalmic division of trigeminal nerve. Coming to contents, it contains internal carotid artery and the periarterial sympathetic plexus around it. It contains third, fourth and ophthalmic and maxillary divisions of the fifth and sixth cranial nerves. The oculomotor, trochlear and ophthalmic nerves course in the lateral wall of cavernous sinus. Tributaries. Intercavernous sinuses are a pair of venous connections that run anterior and posterior to the hypophysis cerebri. They form a circular sinus with the two cavernous sinuses. Cavernous sinus drain the orbit by superior and inferior ophthalmic veins. They drain retina by central retinal vein. They drain cerebral hemispheres by middle and inferior cerebral veins. And they also drain dura by middle meningeal veins and sphenoparietal sinus. Continuing with the tributaries, they empty posteriorly, that is by transverse sinus via superior pectoral sinus, into jugular venous bulb via inferior pectoral sinus, plexus of veins associated with internal carotid artery, empties into pterygoid venous plexus by emissary veins traversing the sphenoidal foramen, foramen ovale and foramen lacerum, facial vein via superior ophthalmic vein. Superior pectoral sinus. It drains cavernous sinus on each side. It empties into transverse sinus. Inferior pectoral sinus drains cavernous sinus on each side, joins the jugular venous bulb. Then we go to study the clinical importance of dural venous sinuses. Aseptic cerebral venous thrombosis is occurring in pregnancy and puerperium and are reported in the Indian subcontinent. The cerebral venous thrombosis constitutes 10 to 15% of the stroke in the young, and it was the commonest cause of stroke in premenopausal women. Coming to age, age-related incidence reveals 3 peaks that are as follows. Infants and young children. So incidents occur due to dehydration associated disease, malnutrition and infections of central nervous system. Young premenopausal women. Frequent use of oral contraceptives is an important etiologic factor. In the elderly, again, prevalence of it is more during malignancies, malnutrition and dehydration associated disorders. Then coming to anatomical basis of cerebral venous thrombosis. Cerebral veins and sinuses have neither any valves or tunica muscularis. Absence of valves permit blood flow in various directions. Absence of tunica muscularis permit veins to remain dilated. Apart from that, venous sinuses are located between the 2 rigid layers of dura mater. This prevents their compression when intracranial pressure rises. Further, emery veins from the scalp, face, paranasal sinuses and ears, diploic veins, meningeal veins drain into cerebral venous plexuses. This explains the frequent occurrence of cerebral venous thrombosis as a complication of infective pathologies in the catchment areas. Example, cavernous sinus thrombosis in facial infections. Example, that is sigmoid sinus thrombosis in chronic otitis media. And another example is sagittal sinus thrombosis in scalp infections. Superior cortical veins drain into superior sagittal sinus against the blood flow in the sinus, thus causing turbulation in the bloodstream. This fact explains greater prevalence of superior sagittal sinus thrombosis. Arachnoid villi are located in the walls of superior sagittal sinus and they drain CSF into the sinus. So, thrombosis, when it develops in the superior sagittal sinus, blocks villi and leads to intracranial hypertension and papilloedema. Coming to effects of pituitary tumors on visual pathway. Pituitary adenomas prevalence is around 17% and comprise a very diverse group of tumors. Pituitary adenomas are considered to be benign. They grow large and extend into surrounding structures, resulting in visual impairment and other neurological impairments. The non-functioning macroadenomas cause neurological symptoms due to intracranial mass effects. Their hormonal inactivity leads to delay in diagnosis compared to functionally pituitary adenomas. Pituitary adenoma types are usually classified into micro, macro and giant adenomas according to their size. Large pituitary adenomas has the higher risk of optic chiasma or optic nerve compression. Then coming to lesions. The typical visual field defect in bitemporal hemianopia is due to anatomical compression of the optic chiasma, as the optic chiasma contains the crossing nasal fibers of each optic nerve. And the second one is if the tumor compresses the optic tract, it causes homonymous hemianopia, and this you can see in the picture, that is in bitemporal hemianopia, both sides of the temporal vision is lost, whereas in homonymous hemianopia, the same side vision is lost.